Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach and Kaigenesis, a range of supplements designed for people diagnosed with chronic kidney disease. Whether you want to lower your creatinine or raise your eGFR or just alkalize, we have products for you. I'm joined again today by the wonderful, the fabulous, the stunningly beautiful Lindsey Zirker. Lindsey is a renal dietitian. She works with the team at Kidney Nutritional Institute with Jessie Anna and everybody, and we have been working our way through minerals, and now we are working our way through hormones. Lindsey is a published author, and she actually wrote the chapter in a new medical textbook coming out on all things hormones. So she is now our circa hormone expert. Lindsey also has a lot of experience when it comes to dialysis patients. You were in the dialysis ward for, I want to say, like 10 plus years, or am I giving you extra mileage there? Or is it, that's about right though, isn't it?
I think I did do it. I had a little bit of a break, so I can't figure out the math, it's too difficult, but something like that.
Yeah. So she has a lot of experience with really end stage chronic renal disease, and yeah. And she's a fabulous, amazingly smart person who goes down rabbit holes, and then we have to dig her out. So,
So
which is what
true.
I love. It's great because I'm like, let me pick your brain from your rabbit hole, Alice. So we are going to talk about the thyroid today. I know we've sort of spoken about the parathyroid, but the link between the thyroid and kidney disease, and what is the link? We do definitely see that the thyroid and things, more hypothyroidism we tend to see with chronic kidney disease. And why is that? So first off, before we go into the thyroid hormones, because there really are sort of three major thyroid hormones that we're looking at, two produced by the thyroid and one by the pituitary gland. So why don't we start with just the thyroid, what it is, and then walk us through why it is linked to kidney disease, and let's walk through the hormones as well. And if I've got questions, I will just interrupt you, but otherwise I'm just going to hand the floor to you and your genius.
Sweet. Okay, so the thyroid is a kind of butterfly-shaped gland that sits in the neck area. And I think we probably talked about this when we talked about all the hormones looking at bone management. But I was thinking how I still see this get confused like on TV and movies and stuff all the time. They're like parathyroid, thyroid, it's like all the
Yeah.
same. And it's like, it's not the same.
Ew.
So, so we have the thyroid butterfly shaped gland. In the back of the thyroid, there's a little spot on each little butterfly wing, and those are the parathyroid glands. And they're such good friends. That's why they have similar names, but their functions, while they overlap a smidgery, they're pretty distinct, right? So we have the
Yeah.
parathyroid hormone, main focus is bone health, and then we have the thyroid hormone, which is like it's like an older sibling.
That's
It's
a good way of
so
describing
bossy. And I can say that because I am an oldest sibling. So,
it. Me too. So there you go.
yeah. So, so that's where it's located, and just remember that important distinction. Um, so it is really focused on uh, your metabolism. The hormones that it produces have a big impact um, on your metabolism and kind of what that means for the rest of your body. So you'll see what I mean by bossy. So it is regulating growth and development and differentiation of cells. So uh, what should this cell become versus that cell? The thyroid is helping to regulate that for all the cells in the body. It is regulating the basal metabolic rate and body temperature. So what is like your body's engine or furnace doing when it's just chilling? It's going
Yeah.
to regulate that. Heart rate, calcium regulation, because it does release calcitonin, which helps to lower calcium levels, where parathyroid hormone helps to raise calcium levels. So there's a little bit of overlap with PTH. Um, it plays a role with carbohydrate, fat, and protein metabolism, vitamin and mineral metabolism imbalance, red blood cell formation, oxygen consumption by your cells and tissues, gut motility, the
Mm.
sensitivity of different hormone receptors like catecholamines, and cholesterol and triglyceride breakdown. So it's kind of like tons of stuff, right?
It's a lot of stuff, especially when it comes to metabolic health. And, we've
Hmm.
spoken about this before, that metabolic disease, meaning inflammation and insulin resistance, is probably one of, I would say, is the driver of chronic kidney disease, because they will both drive type 2 diabetes and heart disease. So
Hmm.
really, when we're looking at metabolic stuff, no, you go, okay, when you start to understand it from that point of view, you go, I can see why there's a link to the thyroid. It's just when it's overtly coming out in symptomology and we're getting changes in hormone levels and that we say it's involved, but it probably is involved even in those smaller cases. We're just not seeing it on labs, right?
I
At
think
least,
so.
yeah.
Yeah, I think we've talked about this before with labs, like the conventional lab ranges, they basically have three like distinctive things. It's the normal range, too high, and too low.
Yeah, exactly.
And and what is more, I think, realistic is what is optimal, which could be really different for each person. Um, and then you have on either side of the optimal range, you have dysfunction, and then you have the too high or too low, indicating a disease state. And so I think that's a really key thing to remember with any lab, but definitely when you're looking at hormones as well.
Yeah, I totally agree. So, okay, so before we dive into its link between the kidneys, let's talk about symptoms of what, now we know what it does. If the thyroid's not functioning in that really narrow, beautiful optimal range, what are symptoms that we would see if we've got a hypo and a hyperthyroid? And actually, what does that mean with labs? Because people get confused. They come back and say, my TSH is high, so I've got a hyperthyroid. I'm like, round the other way. So, yeah, just explain that for people so people really understand the hypo, hyper, and then symptomology of both, and that link to the pituitary gland, and then why TSH and, TSH then producing T3, T4, and why we mean high levels actually mean hypo and low levels mean hyper.
Yes. Yeah. So a lot of the symptoms can be kind of non-specific. So that's why it's a challenge. So I'll do the hyper ones first because I feel like that list somehow seems to be shorter. And
Mm,
I feel like it is quite a bit less common in general, but also in CKD.
yeah, I agree.
Um, so when we think about what the thyroid does, it's regulating how lots of things happen in the body. And if it's hyper, that means a lot of things are going to be sped up. So that means that heart rate is probably going to be increased. It means that people will have unexplainable, very fast weight loss, which we all are probably like, well, how is that bad? But um, it's not very discerning about the type of weight. Um, and so also you're going to have like a increased appetite a lot of times because your body is like burning through all of your fuel and resources. Um, because it impacts gut motility, so people tend to have uh, diarrhea or just like things move through their system really quickly. Um, People can get too low of calcium because the thyroid is releasing too much of that calcitonin. People might run higher body temperatures
Big one.
and be warmer. Um, okay, those are kind of like the big ones. What other ones? Oh,
Oh, the
the
what?
with the eyes, right?
Oh, yeah. If when it's extreme, exophthalmos, where the eyes start to bulge out of the head.
Yeah.
Ones I generally see in clinic where people have been misdiagnosed, they'll be diagnosed as anxiety, so heart palpitations and
Yes.
severe anxiety, and and hair loss. I've never forget having a patient come in and she was in her early 20s with severe anxiety, and I'd been treating her for a while. I'm like, you've just not really got an anxious subtype personality. And she was getting hair loss and heart palpitations. The TSH and T3, T4 were in the lab normal ranges, so we had to scream to get thyroid antibodies run. She had Graves' disease,
Okay.
but her labs were, I mean, yeah, TSH was under 1, but it was still in reference range, and of course T3, T4 were, you know, in the wrong end, but yeah, really interesting. Like the labs weren't blown sideways, but her antibodies were through the roof, and it was Graves' disease. So yeah, really fascinating.
I feel like that's really helpful to consider, because when the symptoms aren't very specific, it's helpful to think about like, okay, what might this look like, and get confused as like, and I feel like that kind of helps you remember the symptoms too. So you can look
Yes,
for
yeah,
those clusters. Yeah.
yeah.
So hypothyroid, where the thyroid is really slow and sluggish. So you're going to have unintentional weight gain or weight loss resistance. Um, those are pretty common. Temperature issues for sure, cold intolerance. Also, it could, I don't really know if I haven't had as many patients with hyperthyroid. I'm trying to think. I've only feel like I've had one, but especially if it is autoimmune disease, that it can fluctuate between normal, hypo, and hyper.
Yes,
And so,
that's very common in hyperthyroidism. Hashimoto's
yes,
versus Graves, yeah.
yeah, so super like challenges with temperature issues. So it can take people a really long time to warm up, also a really long time to cool down. So hot tubs are a problem.
Yes.
um, yeah. Fatigue is a big issue, brain fog, difficulty concentrating, hair loss or thinning hair, specifically like the ends of the eyebrows, is
Yes,
really classic Hashimoto's.
it really is.
Um, Muscle weakness or joint pain, changes in menstruation might be more irregular or heavier or lighter. Skin dryness, especially on the heels. Like there's some like oddly specific
Mm,
symptoms that kind of creep in there that we don't always ask about. Constipation, really common, and high cholesterol and triglycerides. Although I feel like that doesn't really seem to happen until like quite a bit later. Like it's
agreed.
not something that you would see and be like, oh, diagnosis for that. Like that's kind of a complication of later, I feel like.
No, I agree.
Um, Anxiety also here, histamine intolerance and insomnia. Those are all like common symptoms that I see. Any other ones for you on that?
This insomnia, yeah, generally the ones I will see where I'm like thinking about it, but people may not, is that difficulty losing weight, depression, feeling like they've
Hmm.
completely lost their lackluster for life. Yeah, and then slow transit time through the gut. Um, yeah, and then yeah, like you say, it's very specific to that outer eyebrow thinning as well, which I do see. But again, they're very pathological, and they've generally got an autoimmune condition when you see that. And I'm sure you see this. You see these subclinical hyperthyroids where it's not an autoimmune disease, but their TSH is sitting at like 2.75, and that's in range, but what the World Health Organization says that anything over 2.5 is subclinical hyperthyroid, but you'll get the T3, T4 buffering in like the wrong end of the range. And so yeah, I'm putting that towards a metabolic picture with
Hmm.
everything else, and then I'm thinking kidneys, and I might be thinking tubular disease, but that's when I will actually, I'll treat a thyroid at 2.75 if T3, T4 is also looking like it's become resistant and things like that. So yeah, those lab ranges, as you said, optimal and where pathology sits, you know, a TSH of 3, even I've had people come back with a TSH of 4.75, and I think the range is up to 5, and they're like, it's normal. I'm like, it's not normal. T3 and T4 are barely got, they're barely producing anything, and the TSH is like screaming at the thyroid. So yeah, I'm always like, there is like thyroid resistance going on here. So we're looking at insulin resistance, metabolic resistance. So I
Hmm.
see that a lot, like that really, like an insulin resistance, like a thyroid resistance with a really high TSH and then low T3, T4 levels. Do you want to walk through
Yeah.
the labs and what you're looking at? Because I've sort of referred to them a few times now. So
Yeah. So, most commonly when people say, yeah, my doctor, he checked my thyroid, they have a TSH, thyroid stimulating hormone, and that's what they check. And it makes me wonder if people have forgotten how hormones work in the body when they're like,
they
let's
have,
check and
Lindsay,
see
they
if this is
have.
working and just
We're going to
check
check this
TSH.
thyroid by checking the pituitary gland because this makes so much sense to me. And we're going to check your meds to see if they're working by checking the pituitary gland's release versus the thyroid's. Like, I'm like, yeah,
I
I'm with you
mean,
on this one.
yeah. Like the hormones, like they're a whole package deal. They all work together. So if you want to see if something is wrong, then you got to look at all of them so you can put it in context. So yeah, the pituitary gland is what produces TSH. So um, there's a feedback loop. A lot of times the T4 levels, they will give the feedback loop to the pituitary and be like, hey, we're running a little bit low. And so then the pituitary is like, okay. And so it sends a message. Thyroid stimulating hormone is that message, sends that to the thyroid gland and says, hey, we need you to produce some T4. And T4 is less metabolically active. Um, so let me go back to my thing. If I had specifics on how metabolically active it is. Um, well, it's not easily in my notes here, so I might come back to that. So T4, not very metabolically active. So then we have our enzyme, triiodinase. That's what it's called, right? So I know I'm like, where did my note go on that? It's like the picture's like being weird on here. So this enzyme, as maybe you guessed from the name that I hope I said properly, has iodine in it. That's a big part of it. Um, and so that's why there's a lot of attention on iodine and thyroid disease and goiter, because if you don't have enough iodine, then your body can't make that enzyme, and that means you're left with just sad T4, which isn't very active.
No.
Um, and this enzyme actually needs quite a few other vitamins and minerals in order to work as well. So, iodine is a part of it, but then it also needs selenium and zinc and folate and B12 and choline, vitamin C and iron. It needs all these things. And then it will um, it will convert T4 to T3, and this hormone is 3 times more active than T4. And this is what primarily goes and sits in the different receptor sites and helps the body do its job. And so when we're looking at what's going on with the thyroid, um, TSH is helpful to look at. So every lab is going to have their different ranges. Um, but as we know, not everyone's going to feel the same. So yeah, there's a lot of discussion about where optimal ranges are. And this is where I feel like we say this with labs all the time, but labs are just one more piece of data. And the further away they are from the normal range, the more conclusive they might be. But um, yeah, even within the range, there's still quite a bit of room for interpretation. And so when someone is exhibiting like a lot of different thyroid symptoms and they come back and their TSH is in the normal range, like that doesn't mean that they're fine. We want to look at the other things. So a common range is 0.45 to 4.12 milliliters. Did I mess up on my units there? Milliliter, what is that unit? Milliliter units per liter. What is that giant U? I can't remember. Now I don't even know how they measure thyroid hormones. Anyways, that range. But a lot of other functional resources, they say that optimal is a tinier range between 0.5 to 2.5.
Yeah, that's the range I
So,
use.
yeah. So then, so the way, if you're thinking of like recognizing how it works, so TSH is what tells your thyroid to make T4. So if the TSH is low, that means it's, on vacation, it's out to lunch, it's not really like it's not there to stimulate anything, right? So um T4, the range that is common is 0.93 to 1.7, but optimal is kind of close to it, 1 to 1.7, but again, lots of room for flexibility. And so remember, like T4 is nice to have, but it's just not very helpful. And then free T3, you have a typical range would be 2.8 to 4 picograms per milliliter, but optimal 3 to 4, that weird like measurement that now I don't even know what that means. So I'm like, have I ever looked at thyroid lumps before today? I don't know. So there's also reverse T3, which we want to see that less than 15 usually, I think. And reverse T3 happens when let me go back to my things here because now, so it is not very active. It can be converted to from T4 when there's times of stress or infection or things like that, but it's just not really doing much. And so sometimes people, um, their T4 looks normal and they have like a really high T3 and maybe like a higher reverse T3 and a low T3, right?
Yep.
And that's
Yep.
showing inactivity. Yeah.
Yeah, and that generally, as an inflammatory state or
Yeah.
cortisol or stress, will drive a high reverse T3. So your T4 has been converted into reverse T3 versus T3, which is metabolic active. And it's a bit, I call it like thyroid resistance when we have really
Mm-hmm.
high
Yeah.
reverse T3. And so, the summary of that is TSH, thyroid stimulating hormone from the pituitary gland, stimulates T4 in the thyroid. That then needs, and the big ones are iodine and selenium and zinc, and then all the other ones you mentioned. That's why, you often see in lots of thyroid supplement formulas, they've got selenium and things like that in there. You need those cofactors to convert T4 into T3. T3 is what will make it active. What happens is if you've got a hyperthyroid, meaning the thyroid in itself is producing too much thyroid hormones, meaning you'll get an increased T3. That sends a feedback loop up to the pituitary gland, which is why your TSH looks low, because the body's trying to calm down the TSH level so you're not producing so much T3, T4. And then the opposite happens in hypothyroid. You'll get the thyroid going, we don't have enough T3, and so the feedback loop goes up to the pituitary gland, anterior pituitary gland to be specific, and then that will go up and to try and increase T3, T4. So you have to, like you say, look at it as a whole package. You're definitely looking at it in relationship to reverse T3. And if someone is, I say, overt on symptomology, we should definitely also run thyroid antibodies,
Mm-hmm.
to check for autoimmune part, where then what happens is the immune system will attack the thyroid. You've got Graves' disease and you've got Hashimoto's. Hashimoto's can look both like Graves, and so hyper and hypo, whereas Graves doesn't tend to swing. Graves tends to be very specific in the hyper state. And so, yeah, you've got different antibodies will go out into different parts of the thyroid, and I can't remember the nuance between Graves and Hashimoto's as far as what part of the thyroid's been attacked. But that is that big feedback complicated loop, and it definitely why it's so important in metabolic diseases. We talk about insulin resistance a lot. We also get this thyroid resistance, and it's part of this whole pathway that sort of blows out when the entire metabolism falls over. So that's the thyroid and thyroid disease explained. Now, why does this have anything to do with the kidneys? Like, why are we even thinking about the thyroid when it comes to kidney disease?
Yes. So thyroid disease in general is pretty common. Like
Yeah.
it's in America at least.
Oh, it's same in
Uh,
Australia.
yeah, they estimate at least 20 million Americans they have some kind of thyroid disease. And 99% of thyroid disease is hypothyroidism. And of that, they also say I've seen statistics between 70 to 90% of that is autoimmune.
Oh, wow,
Um,
that's much higher than I thought.
yeah. So, but in conventional medicine, they don't treat autoimmune thyroid disease any differently than just primary or secondary hypothyroidism. So that's
True
why
story.
often the distinction doesn't get made, why they don't typically test for antibodies. But again, it's like it's all a part of, context for things because, yeah, well, I think there's more we can even say about that later. But in kidney disease, it is interesting that there is increased risk of thyroid disease and kidney disease that is not autoimmune,
Yes.
which I thought was really interesting because I was always like, oh, you have hypothyroidism, maybe it's autoimmune. But then, like, none of my patients were coming back with antibodies. And so that's when I was digging further and it's like, no. So, what the connection with kidney and thyroid, sometimes it's hard to know if it's a chicken or if it was the egg.
Yeah.
So, if we're thinking about how does the thyroid impact the kidneys? Well, remember how the thyroid is super bossy. In a hypothyroid state, we have a lower heart rate, which also there's reduced cardiac contractibility. So the heart like contraction isn't as strong. That means there's reduced cardiac output. So that means there is going to be less blood flow. Um, and in the end, that really leads to reduced blood flow to the kidneys. And also, as kind of a side quest with the thyroid, it does play a big role in the production of nitric oxide. And so that also reduces blood flow to the kidneys. And so it kind of boils down to that if people have really poorly managed thyroid disease, it can have a slow ischemic injury to the kidneys. So a slow oxygen deprivation to the kidneys, and that can cause reduced kidney function. But the studies have found that the GFR that is impacted primarily by low thyroid, it can be reversibly decreased by as much as 40% in more than half of people who have hypothyroidism.
Wow.
So yeah, so you could have your kidney function 40% lower just because hypothyroid, and it's reversible. So get your thyroid back on track and boop, back goes your GFR. I've seen that even with patients who don't have a thyroid because of thyroid cancer.
Yeah, right.
Yeah.
So just better management with their meds.
Yeah, I don't know what happened. He was doing fine, and then the doctor reduced down his medication. His TSH went up to 9.
Ooh.
And I said, "You're so like diligent in all these things, but this is such a big problem that we're not going to make any headway on your kidneys until this gets figured out. And the doctor was so conservative that it took 4 months for us to get for him to adjust that medication and get the TSH back in a normal range. But as soon as he did, his kidney function popped back up to where it was before he had that weird thyroid situation.
Okay, so you've seen it bounce.
Yeah.
So important. So here's a big question, and I'm sure people are thinking this listening. How many times is chronic kidney disease mismanaged or non-diagnosed hyperthyroidism? Because the hyperthyroidism is so common, so ridiculously common that and 9 times out of 10 doctors are only checking TSH. They don't check T3 T4. I have to scream off the rooftops to get T3 T4, let alone, let's not even talk about autoantibodies. But as you mentioned, most thyroid disease is non-autoimmune related. So if you start to think about that whole pathway and nitric oxide and no ischemic flow, which is going to increase, I guess, the fibrosis process is what I would be thinking.
Yeah.
It's going to increase through there, and oxygen starvation into a very, very hyperperfused tissue that
Yeah.
has should have a lot of blood flow going through it. So of course it's going to shut down. What percentage do you think of kidney disease that looks idiopathic might actually just be related to the thyroid? Opens up a big can of
I
worms, doesn't it?
I think, I mean, we know that there's like, like diabetes. So if someone has thyroid and diabetes and the thyroid is mismanaged, I think like we would see a quicker progression of
Yeah.
the kidney disease. And then once, things are better managed, we could see potentially an improvement, but because the diabetes is also there. So I feel like if there's like unknown reasons for the kidney function dropping, then yeah, I would 100% be checking that thyroid just because it's like, well, that's an easy thing to rule out. And I think, again, the context is challenging because if the doctor like draws only TSH and it's in the normal range or on the low end, then and he's not seeing like what's going on with T4 or T3, like he's not going to know if the feedback loop is or isn't working. So he could think, oh, well, your thyroid is just fine, or maybe he's gonna, think, oh, well, maybe it's hyper, but it could still be hypo
Yeah.
because, yeah. So yeah, I don't know. There could be a lot, and even on top of that, we'll talk more with some of the other pieces, but like with the medications and stuff, I think there's additional pitfalls for our patients. But yeah, because once, if the person has mismanaged hypothyroid and it's having this negative impact on the kidney, so they're going to be more susceptible to nephrotoxic medications or infections or all these other things that normally the kidney might withstand, but because it's a little bit feeble. And then once kidney disease sets in, the reduced GFR is going to reduce the clearance of all these inflammatory things. These inflammatory factors, they inhibit the expression of our little deiodinase enzyme. So you're not going to have very good conversion of T4 to T3.
Yeah.
And
You're
T3,
getting
low
high
T3,
dose yeah.
that is the most common finding in kidney disease patients. Normal
Yeah.
TSH, normal T4, SAD T3.
Yeah.
Um, So and so then that's how we see, thyroid dysfunction starting to happen there. Also, uremia just messes up every system in the body. Like it's just so insidious.
Yeah.
Um, it will blunt the response of the TSH receptors. So again, that feedback loop, it's not very good. Um, and so like there's just all these things that kidney disease starts impacting, and so you're just not going to have good conversion. The communication is just all messed up. And so it creates quite a challenge for people.
So
Um,
yeah, keep going. I was going to say the rabbit hole of medication feels like that's a piece
yeah,
you want
that's what I was thinking too.
to.
So the the thing with the medications is, so most of the time people are going to be taking um, like Synthroid or levothyroxine, and those are lovely synthetic T4 hormones.
Yes.
So if you don't have enough zinc, if you don't have enough iodine, if you don't have all those other vitamins and minerals we talked about, then your T4 medication is not helpful. It's not doing anything at all.
No.
And so, like sometimes they're like, oh, well, people just aren't responding to this. And I'm like, well, why aren't you looking at their micronutrients? So that's one of the things that I feel like I can help with is say, you're on a T4. Let's assess your micronutrients and make sure that you're giving the body the resources it needs to work with that medication. Um, there are other medications like Cytomel, which is a T3 only. Um, but I think most people seem to do better on a T3, T4 combination. Um, and so those ones typically, synthetic T3, T4 medications are usually compounded at pharmacies, or they have a natural T3, T4 like Armor Thyroid, NP
Yeah.
Thyroid, West Thyroid, ones like that. And people seem to like often feel better on those, probably because they have micronutrient deficiencies and probably because there's T3, so it kind of masks that issue.
Yeah.
Yeah.
Yeah. Yeah, most of the time people are on thyroid. And it's interesting, like back in the old school days before drug companies made synthetics, we were using desiccated thyroid from pig extract and great
Yep.
results. And then we
Mm-hmm.
went to synthetic. But if you go back to using desiccated thyroid, far less side effects. And as long as you've got the micronutrients intact, I think it's a far, from a natural, I'm talking natural medicine perspective, but
Yeah.
we can often get thyroids under control with desiccated thyroid and then micronutrient support. You don't then get all the toxic side effects. Your kidneys are going to thank you for that because they're not filtering all of that stuff out.
Mm-hmm.
It's far more bioidentical. Um, as far as that. Plus, then I can go down the rabbit hole of thyroid bioregulators, but they really help as well. So, yeah, I feel like I think I've got a big frustration with thyroid disease because I just don't ever really see it treated very well or detected well. It's not tested for well. Even in my patients with confirmed diagnosed autoimmune thyroid disease, I have to jump up and down every time to get T3, T4, TSH, and antibodies because I'm like, well, I need to know if there's still a huge inflammatory process going on, so I actually need thyroid antibody levels. I've got is she Graves? No, she's Hashimoto's. Yes, she's Hashimoto's. But her TSH, T3, T4, beautiful. We've got all the micronutrients. In fact, she doesn't need to take any thyroid medication because we've got all the micronutrients working properly. But her thyroid antibodies are still elevated. So I'm like, okay, that's an autoimmune inflammatory thing. You treat that very differently. Then we've obviously got all the micronutrients going, and that's lovely. But yeah, it really, you have to have all of that and reverse T3, to,
Mm-hmm.
and I would say inflammatory levels and cortisol and DHEA and kidney function, then you can really start to treat someone, and insulin, and because I think it's very metabolic. Then you can really treat someone holistically versus just having a TSH. I don't know, honestly, I don't know how anyone can treat off a TSH because it doesn't tell me really anything.
Well, that explains the predicament you were talking about. That's exactly what they're doing and why it's not treated well, because they're just doing it off TSH.
Yeah.
So, and yeah, I do think it is important to consider like all those other pieces of the puzzle. Another one that is really important is the adrenal
Yes,
situation
thank you.
with
Yes.
patients. Um, uh, my doctor kind of explained it to me because I have Hashimoto's, And she said, the thyroid is the general, but the adrenal glands are the soldiers. So, like, yeah, the adrenals, they're not really going to have clear direction if they're not getting orders from the thyroid. But also, if your adrenals are toasted because you suck at managing stress, what? Um,
You
then
can say this because you totally have
yeah.
win to say
What?
that.
Do people have that problem? Did I? Um, then when sometimes, well, a lot of times, if that hasn't been considered, people start on a thyroid medication and they actually feel worse because their adrenals are in really sad shape. And so you have to uh, consider that, make sure that the adrenals are working well before loading up with thyroid hormone, which is a challenge because conventional medicine, they don't like the term adrenal fatigue, so I'm not really sure what to call it, but they don't want to acknowledge that that is a thing. So I think that's another reason why thyroid disease just really isn't treated well, is because we really have to think upstream and downstream and sideways and diagonal, because thyroid is so interconnected with things. So it's a big
Yeah,
challenge.
yeah, it really is, and it's such a good point. Okay, well, I feel like the summary of all of that is if you've got a sad thyroid, especially hypothyroidism, poor micronutrients, so no conversion or reduced conversion T4 to T3, you're going to have reduced blood flow in the kidneys. Reduction in blood flow in a very vascular organ is going to cause a decrease in EGFR, and you were saying 40% by just improving that T3 to T4 conversion and getting that to work again will give you back, full kidney function by just improving hyperperfusion through the kidney tissue. And poof, chronic kidney disease disappears because you've corrected the thyroid. So you suddenly realize how important it is to screen thyroid and keep an eye on it as part of your annual, especially if you've got a history, I would say every 6 months, but, as part of an annual kidney checkup, if you've got chronic kidney disease, you want to make sure that your thyroid is in tip-top condition through all of this to make sure that you're not accelerating EGFR decline.
I think it's especially pertinent if you're seeing that GFR decline, but you really aren't experiencing proteinuria. I feel like that's a big key, because if there is proteinuria, then 100% like there's other factors at
Yeah,
play. But if you're just
there's
seeing
glomerular
that
damage.
decline and
Yeah,
you're just like, and your doctor's like, oh, it's fine, you don't have protein in your urine, like I think that the thyroid could be a really easy, like it's a low-hanging fruit to explore, but and then you'd probably be more likely to see that improvement in the GFR. But if you're still seeing lots of proteinuria and that decline, thyroid is a part probably, but not as big as it would be if you didn't have it, I think.
very good distinction. Thank you for that.
Yeah.
Okay, well, I mean, it really is fascinating when you get into the nuts and bolts of it. Is there anything else with this thyroid kidney connection that we haven't covered that you feel like is really important to discuss?
Yeah. With hormones, where, so we've kind of talked about like where's it coming from and is it getting converted. The other piece is the receptors. And so um, sometimes we can look at thyroid labs and we see like maybe a higher T3, normalish T4, and then a low TSH, and then people have hypothyroid symptoms. And you're like, what? That should make you think, I think something is going on with the receptors. And so sometimes this can be a genetic issue, like the receptors are a little bit wonky or off, and so the hormone can't sit quite right in there. But in kidney disease, the more common issue I would expect is that toxins compete and will sit in receptor sites. And so that's why that uh, uremia is just such a big problem, because all those toxins running amok, sitting in those receptor sites. So T3 is ready and raring to go and be helpful, but it can't because it's got an imposter in there. And so that's another piece of the puzzles to consider, like, is like the thyroid not being produced, or is the hormone not being produced? Is it not getting converted? Is the receptor issue not working? Is the feedback loop not working? Like, there's a lot of breakdowns to consider for it.
And how would you treat a receptor site issue? How, because there's no meds for that, so we are having to look at natural medicine. So, I mean, I know what I do, but what are you thinking when you're thinking, okay, this actually is a receptor site issue?
Yeah, if I'm suspicious about a receptor site issue and toxins sitting in there, um, especially if they have other autoimmune stuff going on, like if they have autoimmune kidney disease on top of it, I'm definitely thinking about environmental toxin piece.
Yeah,
And so I'd like do like a symptom questionnaire, if they if it works with their resources to do like a total tox test. I'd be really
yeah.
interested to see that. If we do like genetic SNP testing, I'd be looking for detox pathway SNPs. But the more common thing is I would actually start looking at the gut, because the gut is such a huge producer of toxins. You know, we hear a lot about indoxyl sulfate, p-cressyl sulfate, lipopolysaccharides, um, those kind of things. They're all produced in the gut. And so I would look at like the Renadil probiotic that helps break down those uremic toxins, and then colostrum supplements, um, uh, Megaspore. Is that the name of that company? I can't.
Yeah, that's the soil-based one you're thinking of?
Yeah, they've got like Mega IgG 2000. There's another company that has like a SBI Protect, and then the Mega IgG 2000. They also, that company has a Mega Mucosa. They all have those immunoglobulins in them, and those all bind up LPS. And
Mm,
so I feel like that's a really common thing I would do, especially if there's, again, other autoimmune stuff going on, because it's going to be huge in calming down the immune system, helping to heal the gut, and then it's just going to get rid of those toxins so they're not even there to sit in receptor sites. So those are kind of some of the bigger things that I look at, seeing if that's a good option. The other thing is making sure they're getting the right amount and type of protein, because that's going to fuel uremic toxins, and also
mm,
make sure their digestion is working well, because if you're digesting and breaking down your protein well, there's less protein for the gut bacteria to break down and make toxins from.
yeah.
So that's my other pieces. So what
Yeah.
other things do you do for?
I see celiac or non-celiac gluten sensitivity being a huge part in
Mm,
hypothyroidism. So I generally am putting on people on gluten restrictive diets. You know, especially we know that makes a huge difference in IgA nephropathy. So that autoimmune picture, especially, but hypothyroidism, even without the autoimmune picture, seems to respond very well to a gluten-free diet, and that can be down to the glyphosate. We know glyphosate
mm-hmm.
bind into the receptors. I like
Yep.
Pectosol, and the brand Pectosol, which is citrus pectin, which is a binder. Great if you've got
Oh,
mycotoxins.
yeah.
It's probably
Mm-hmm.
my favourite of the binders because it's got the most clinical research behind it. But glyphosate, I think, is one of, and organophosphates, but glyphosate, I think, is a really big one that sits into those thyroid receptors.
I think you're right.
Yeah, so Pectosol generally, and then bumping up glutathione and superoxidase dismutase as well, just to clear that out. So, but everything that you said, I'd add on a low, or I'd remove gluten out of the diet, and then probably add in Pectosol for that binding part, and then yeah, and then making sure your cofactors are there as well. So, and then, looking at things like insulin resistance, because we know when you've got high cortisol, all receptors get dulled or blunted basically. So then just looking at that cortisol picture too. So, but yeah, otherwise
Mm-hmm.
very similar. So yeah, this is where it comes down to treating a person and not a disease, and cause, not the effect, huh? Super
Yeah.
important. It's a big combo. You can start to see why just treating disease, like, oh, and in isolation, like you've got thyroid and you've got kidney disease, we'll treat them completely separately, versus how you and I would look at it and go, no, they're like same side of the coin, maybe they've got these high uremic toxins because they've had mold exposure, and we actually need to go and do a massive mop up, and that is actually, affecting all the receptor sites. They've got decreased nitric oxide production, which is then further increasing lack of blood flow going through the kidney. You start to see these big complex pictures when you start to tease all of this stuff out and actually start to treat the person. So I find this is where, integrative medicine and integrative practitioners and people that think outside the box, and back to the point that you and I make all the time, which is practitioners that are curious and will go down the rabbit hole and figure all of this out. You can tease all of this stuff out and actually get people really well versus treating people and their conditions in isolation. Like, here's some Armour-Force, and here's a diuretic, and a low potassium diet, and go along your merry way. And you and I would just not do any of those things. We'd be like, hang on a minute, like, we need to get right to the bottom of all of this. Like, what is actually going on here? So I think these pictures start to really highlight how we look at this very differently from a very tunnel focused, chop you up into bits and treat everything separately, mechanistic model versus how we tackle this. I think it's a really good highlight when we start to dig into the hormones. So yeah,
I think it's just also, like, as a practitioner, I feel like it's such a more interesting way to look at it. Like, I
totally.
feel like it keeps, like, me so much more engaged and learning when I think, well, why is that doing that? And why wouldn't this work? Like, why didn't that work? Why did this? I just feel like it's so much more engaging, and it helps prevent burnout because you're interested and you like it. I don't know. I'm like, why do you want to, like, practice that other boring way? Like, no.
Yeah, you and I are super curious though. So, but yeah, no, I'm with you. Like, I really do get curious about all of this stuff and love going
Yeah.
down and picking all of this apart, because long term you see people get really well, and that's the aim, isn't it? So
Yeah.
yeah,
Yeah.
awesome. Anything else you want to say before we wrap this up?
Um, I might say this, like, at the end of every hormone thing that we do. Mainly, like, it's a little bit of a mantra I say to myself, because hormones feel really complex to me. Like, I feel like the more I learn, I'm like, oh, I didn't, like, think as, you know, broadly as I needed to, or whatever. So I feel like hormones are really complicated, because especially when we're used to, like, relying on lab results for things to corroborate what we're seeing with symptoms or
Yeah,
conditions. But hormone testing is really shady because it's impacted by circadian rhythms. And even one of the things that I found when I was researching it, I was like, oh, there's just, like, natural times of the year when certain hormones are higher. Um, like, not even just during the day, but like, TSH just seems to be higher in the summer, and T4 is higher in the winter, and things like that. And so hormone testing is really challenging, because of that. And then, stress and other psychological factors, like, you've brought cortisol up a few times, and it's really important to remember that, because cortisol is going to suppress other endocrine functions, and increase others. It's just going to make things, like, really wild. And so, again, maybe you do look at the full thyroid panel, but if you're not taking into account if um, cortisol is running amok, like, you could totally misinterpret things. So it feels so complicated. And so for myself, I think, okay, how can I keep things as simple as possible and as in context as possible? And for hormones, I feel like there's three main things that, if these are out of whack, then, if you don't, like, know hormones and hormone testing well enough, then you're gonna misread things. So, um, macro and micronutrient nourishment. You have to be eating enough food, and you've got to have enough protein, fats, and carbs, and you have to have all those cofactors. If you don't, then you're toast. And so that kind of goes back to a lot of the concerns that people are like, oh, follow this restriction, that restriction. No restriction can be more important than nourishing your body. Like that
Totally
just,
agree.
that's like the first rule. Always nourish your body. And then stress management. Like it really, like we know it's rolling chronic disease, but with hormones, there's so much involvement there. And so if that is really poorly managed, then things are going to be masked by it. And then toxin exposure. This is another really big piece that will really throw off hormones.
Yeah.
And so I feel like if you're thinking, this feels really complicated. I can't remember why TSH is high or low or the ranges or all those things. You don't have to remember that really. Like even as a provider or a patient, like think of those foundational pieces. Do we have a good handle on what's going on with toxins? Are you or your patient well nourished? What's going on with the stress management piece? If you feel, and then if those things are really well in place and things are still weird, it's going to be more clear of what is actually happening. Because when things are out, it's just going to mask everything. Everything is going to be so confusing to try and muddle through. And a lot of hormones, they are going to improve and fall back into place once those three things are happy. So, as interesting and rabbit holey as I like to get with things, at the same time, it's just like there's still so much we don't know, but we know enough to take care of some basics. So, that's what we can do. And I think it's nice too because that keeps it simpler for everyone because like we don't want these big complicated interventions for people that cause more stress that aren't sustainable. um, we don't want that, so keeping it simple with any kind of hormones or diets or whatever, that's going to make things more successful for anybody.
Yeah, I think that's a really great summary. Well, if anyone out there is thinking, holy cow, I need Lindsay to have a look at my hormones and in relation to my kidney function, you can find her at kidneynutritionalinstitute.org. I will put the web link below. She works with people all over the world because of the wonders of telehealth. If you want to know more about what we do, head to www.kidneycoach.com. You'll find us on Instagram and Facebook under the same handle. I'm sure we'll put some posts up around this. I think it's a really interesting topic, excuse me, and one that people aren't looking at enough and going down that rabbit hole. Lindsay, as always, thank you for your knowledge and wisdom. I think we're going to tackle insulin next time.
Yeah, insulin next time.
Awesome. All right. Thanks again for being part of our community. Make sure you hit subscribe and like. That way you'll get notifications anytime we put up new content. And if you have any comments about this or if this has been your journey, please put some comments below. We'd love to hear from you. Thanks again for being part of our community. Lindsay, thank you so much for your knowledge, brain and wisdom. And we look forward to seeing you next time. Bye.
Bye, everyone.